Hello everyone, myself Dr. Gulabsi Vamania, third year resident doctor, Radiology Department, CUSA Medical College and Hospital, Surendnagar. Today I am presenting case of cesarean scar ectopic pregnancy in the case of the week series. Patient history: a 30-year-old female, gravida 2, para 1, presented gynecology department at CUSA Hospital, Surendnagar with a history of amenorrhea of 7 to 8 weeks, accompanied by mild lower abdominal pain and spotting per vaginum. She had an obstetric history of one previous lower segment cesarean section performed by 2 years earlier. There was no history of fever, heavy bleeding, or syncopal episodes. On examination, the patient was hemodynamically stable. Laboratory findings: urine pregnancy test positive, serum beta HCG level elevated and consistent with early pregnancy. Imaging findings: transvaginal and transabdominal ultrasound with color Doppler, empty uterine cavity and cervical canal, gestational sac located in the lower uterine segment at the cesarean scar site, thin or absent myometrium between the gestational sac and urinary bladder, increased peritrophoblastic vascularity on color Doppler. This is a UAG images on longitudinal and transverse section of per abdomen scan and longitudinal section of per vaginal scan. Result: the ultrasonographic investigation carried out in this case showed the finding of single intrauterine gestational sac at the site of scar. Adjacent myometrium to the sac shows marked thinning with maximum thickness 5 mm. Fetal cardiac pulsation present at the timing of scanning. After informed consent, all of the above findings were also confirmed by per vaginal ultrasonography, CRL 8 weeks 2 days. Follow-up: this patient, abortion done by methotrexate therapy. Case discussion: cesarean scar ectopic pregnancy represent a rare and potentially life-threatening form of ectopic gestation resulting from implantation of the fertilized ovum within the fibrous tissue of previous cesarean section scar. The increasing incidence of cesarean scar ectopic pregnancy parallels the rising rate of cesarean deliveries and improved early pregnancy imaging. The pathophysiology involves implantation through a microscopic dehiscent tract in the myometrium at the scar site, allowing trophoblastic invasion into the myometrial defect. If undiagnosed, progressive growth may lead to uterine rupture, massive hemorrhage, and placental adherence disorders. Imaging play a pivotal role in diagnosis. Transvaginal ultrasound with color Doppler, it is a modality of choice, typically demonstrating at empty uterine cavity and cervical canal with a gestational sac embedded in the lower uterine segment at the scar site. Associated findings include thinning or absence of myometrium between the sac and urinary bladder and prominent peritrophoblastic vascularity with low resistant flow. These imaging features help differentiate cesarean scar ectopic pregnancy from cervical pregnancy and low-lying intrauterine pregnancy, which have overlapping clinical presentation. MRI serves as a complementary imaging modality, particularly in equivocal cases or when planning management. If accurately delineates the depth of myometrial invasion, serosal integrity, and possible bladder involvement, which are crucial in selecting conservative versus surgical treatment. Early diagnosis allow fertility preserving management options such as systemic or local methotrexate therapy, ultrasound guided sac aspiration, or uterine artery embolization. If delay diagnosis done, surgical intervention required, including hysterectomy, especially in case complicated by hemorrhage or uterine rupture. Conclusions: cesarean scar ectopic pregnancy is a rare but serious complication of previous cesarean delivery. Early and accurate diagnosis using transvaginal ultrasonography with color Doppler is crucial for preventing life-threatening complications. Recognition of key imaging features such as empty uterine cavity, gestational sac at the cesarean scar site, and increased peritrophoblastic vascularity. Conservative management options including medical therapy can be successfully employed in hemodynamically stable patients with preserved fertility goals. Increased awareness among clinicians and radiologists is essential for early detection, appropriate management, and improved maternal outcome. Thank you. Specially thanks Dr. Nirmala Chudasma ma'am for constant guidance and support.